Hi, good evening, everyone. My name is Dr. Catherine Palmerola, and I'm one of the fertility docs at IVFMD, our South Miami location. And I'm going to be joined shortly by Dr. Duro of Florida Complete Wellness. She's our go-to acupuncturist for all of our patients who are looking to conceive, and I see her here. Hi, Farrar. There we go. Just going to add in. Just waiting for Farrar to join me. Here she comes. Hi,
good.
Hi, Duro.
Nice to see you.
I'm great. How are you? Good. Always nervous that I get the technology right, but Shirley helps me every single time, so it's worked out again. Happy Wednesday. So I was just briefly introducing the session again. I'll introduce myself. If you could introduce yourself as well, Dr. Duro, and then we have some excellent questions that we can dive right into.
I'm a licensed acupuncture physician, and we're in Hialeah Gardens actually, but we work with patients from all the way from South Miami through Broward and some in Palm Beach. And we do have another location, Coral Springs, too. But we, basically just work with women and families and people of all stages trying to get their reproductive hormones in order, and also throughout pregnancy as well. And we've had lots of pregnancies lately from your clinic. I see there's so many. So it's
That's so wonderful to hear. Dr. Duro, you're an amazing part of our treatment process. And, I always tell patients like acupuncture, I don't think it can be harmful. Some people have the needle phobia, but it can only help us at a minimum relaxation. I find it relaxing, but also potentially help our ovary status, our uterus.
Thank you.
You guys are
amazing
to have you as
I feel like
part of our team.
There's no stone left unturned when someone goes to see you guys. Like literally everything is. I feel like so relaxed. I'm like, oh, good. Okay, you're gonna have every single thing, known to me unchecked. So that's good. Awesome.
You're good. Oh, yeah. So briefly, I'm Catherine Palmerola. I'm one of the fertility docs at the South Miami location. I primarily am at the South Miami location, but we see virtual patients who can be from anywhere in the state, anywhere in the country. I happen to have many international patients right now. It's been a very international week for me. So we're here based in South Miami, but available for anybody. And one of my patients is saying hi.
What's the furthest away that you've ever treated anyone?
Coming up on our transfer soon. Ooh, that's a good. Well, I've had Spain and England. I would say, we have quite a number of Latin America, South American patients, Caribbean, many patients. But then I did have a couple from London and Spain. Yeah. So I would say, that's coming from across the pond. Yeah. Cool. Awesome. So we've had a number of questions that have been sent in. I see also some questions that are coming through the filter here. So we have plenty of time to get to everything.
Everyone, don't be shy.
Always a good conversation in these sessions.
Type in your questions in the chat, and we'll answer also the ones that were pre-submitted too.
Exactly.
But as always, you guys are welcome to comment and share. If you have friends struggling, please share this with them. You can hit the little share button and send it to someone who might be struggling right now, and hopefully this will be helpful for them.
Definitely. Well, one of the questions that was submitted through our question box was the success of a euploid 6AB embryo. So first of all, congratulations on this beautiful embryo. A 6AB is the top of the line in terms of the grade. The grade is a little bit like a beauty contest We give the outer shell of the embryo, the part that becomes the placenta, that gets given a grade. It happens to be the second letter. The inner cell mass, which becomes the baby, that also gets given a letter grade, just like in school, ABC. And so that's what gives us the combination of the two letters, inner cell mass and outer trifecta. So at least in our lab, a grade of an AB, that's very rarely given out. So very, very high quality embryo. But most importantly, its genetics are normal. And so I can't speak to where this embryo was made, but according to our lab at IVFMD, with a normal embryo, we should have a 65 to 75% chance of a baby from that embryo, regardless of your age. But there are other factors that are very important for the success of the embryo, the environment, the uterus. So are there fibroids? Are there polyps? Is there scar tissue? Has there been prior surgeries on the uterus? What is your weight? Do you have medical problems? All of those will also impact the success of the embryo. So I can't give you an exact number, but statistically, that awesome. Beautiful normal embryo should do very, very well. Yeah, exactly. Other questions that have been sent in. So someone unfortunately has experienced multiple miscarriages after 6 weeks, even after a heartbeat's been detected, even after genetically normal embryos. So first of all, I'm so sorry. This is terrible. You know, what you're going through is, actually a very rare portion of the population. What you're experiencing is recurrent pregnancy loss or recurrent miscarriage. And especially after a genetically normal embryo, this unfortunately is rare. So if this has happened multiple times, I would definitely recommend having a workup for miscarriages. Beyond the genetics, is there something else that is causing the miscarriages? Blood clotting factors, hormone factors, autoimmune factors, uterine factors. There could be a number of other reasons that the miscarriages are happening. So if you haven't had an extensive miscarriage testing workup, I would. If you're not having acupuncture, I would seek out an acupuncturist.
You have to come in and get
you're my treatment for all maladies, Dr. Duro. I know.
Well, I know.
Any
next
offices
time
opening in Miami?
Would you say? I'll pop in your office, put some needles in there. I do come for transfers a lot there, but I know you guys are so busy. Yeah. So. But I think that's one of the most heartbreaking things is when you don't know what's happening. Why is it happening with the miscarriages? And even when there's testing, sometimes you still don't know. So you just do all that you can to support your body and hopefully create the right environment, work on stress, try to, help with diet, certain nutrients like NAC is also, there's a study from Japan about that with recurrent miscarriage. It's one of the few supplements that was actually studied for recurrent pregnancy loss when they actually studied women who were pregnant taking it. And so these things are actually, there are a few things you can do, but I think we're beyond the stage where we're just well, just sit back and just keep watching it happen. That's not good.
Oh, no. And the OBGYN, the general OBGYNs, they typically wait for you to have 3 miscarriages before you undergo testing. As fertility providers, we often are more swift to do a workup. And I would say after 2 miscarriages, especially after a normal pregnancy loss, genetically normal pregnancy loss, I would consider a workup. And excuse me, I have a lingering cough.
You might see my dog run around.
Apologize in advance for multiple coughs.
Start barking. He's a little hyper right now. Go through a few of the questions on is ICSI painful? That's what I just saw that question come up. So would you maybe the embryo?
Is ICSI painful? To you, absolutely not. This is a procedure that happens on the embryo, so you will feel nothing. but so what does ICSI stand for? Intracytoplasmic Sperm Injection, ICSI. And this is a procedure to place the sperm into the egg, as opposed to, say, conventional insemination, where we allow the sperm, hundreds of thousands of sperm to just commingle with the egg and allow them to fertilize naturally. So ICSI is extremely common in the embryology lab, and it involves a needle poking into the egg, which might be uncomfortable, but the egg is a single cell, which doesn't have pain receptors, to my knowledge.
Is there any
so
damage to
I don't
the
think
egg,
this
do you
is a
think,
painful
from it,
process for the egg.
Is there?
From ICSI? So absolutely, we have to have trained embryologists in this procedure. So it's a procedure that is a skill, and if in untrained hands, absolutely there could be damage, but it's a learned, trained skill that embryologists become fluent with, and
Must be
in
a
the right
tiny
hands,
needle, right?
there's
That's
no
such a
damage
tiny,
to the cell, to the egg. It's a microscopic needle, microscopic. And they can actually learn a lot of information from the actual ICSI procedure. As it penetrates the shell or the outer layers of the egg, the embryologists get feedback on, oh, does this feel like a normal resistance? Is there no resistance? Is it very hard? So our embryologists at least make comments on how it felt by injecting the sperm into the egg. And that's how we can, I gather information about egg quality from their descriptions of, no resistance or very sticky cytoplasm
they're able
as they
to have
were
that feedback.
injecting the egg. Yeah.
There is a question about, besides IUI, what other procedures are there before considering IVF?
Yeah, so I would say in general, we have two main types of treatment. Less invasive, like things like timed intercourse or insemination, which might involve watching a natural egg release, not using any medications, and doing insemination. We can use medications instead of releasing one egg. Maybe we try to release 2 or 3 eggs. We can do that with a pill and monitor to see when ovulation occurs. We can help ovulation. We can time sex or time insemination. I would all classify that as, a more conservative approach, less invasive. Then we have IVF, which is the opposite extreme. Medications to stimulate lots of eggs, procedure to take the eggs out, making embryos in a lab. And I really would say we have those two pillars of treatment. There's lots of variation within the conservative approach, whether we use pills or no pills or sometimes injections, intercourse or insemination, but I all kind of group it into one type of treatment. And then there's IVF, and there's not,
someone asked, do you do
in my
ICSI
opinion,
on
anything
all
in between.
patients for IVF? Talking still about ICSI.
Yeah, so I would say the majority of patients these days are getting ICSI because of either sperm concerns, okay? If there's any concern with the sperm morphology, shape of sperm, or any of the sperm parameters, ICSI is our best treatment. If we're doing genetic testing on the embryos, which more and more patients are doing genetic testing of their embryos, ICSI is the best fertilization method, so we don't introduce sperm contamination through conventional insemination. But if we are not doing ICSI, if we're not doing genetic testing, if we have 100% perfect sperm parameters, we would not necessarily need to do ICSI. No,
and
conventional insemination it is.
Did we have any more ICSI questions? No, we had one about fresh versus, what are the pros and cons of frozen versus fresh transfer of day 5 blastocysts?
Yeah. So almost always we prefer frozen transfer. And that is a recent trend, okay? Back in the past, when we were first developing IVF, we weren't very good at freezing embryos. It was a risky procedure. It was considered our last, we prefer to do it fresh, but if we have extra, we'll try to freeze them, but we prefer fresh. Mostly because the freezing technology, cryopreservation, was imperfect, and our survival of the embryos was suboptimal. Now the freezing technology is amazing, and our embryo survival rate is 99% in most scenarios. So when at the end of an IVF cycle, hormones are really high. This is not the best time to be pregnant. It's not physiologic. We have risk of overstimulation. So once our freezing technology improved, the trend was to now do frozen transfers. We allow hormones to come back to baseline, and we can try for pregnancy the very next month under physiologic conditions. Hormones are where they would be in a normal period cycle. Our embryos survive this process no problem. And comparing fresh versus frozen, we are doing better with fresh embryo transfers. Sorry, excuse me, I misspoke. We're now doing better with frozen embryo transfers for all of those mostly hormone physiologic reasons. Now, there's an exception. For some couples, their embryos, for whatever reason, they cannot be frozen because of their quality. They don't tolerate the freezing unfreezing process. Maybe we don't have many eggs or embryos to begin with. And so for a select patient, discussion with your doctor, a fresh might be a consideration for you.
I don't know if you've ever seen the movie Interstellar.
Did you ever see that? Frozen.
It's like one of my favorite movies. It's a sci-fi, but basically they're colonizing different planets. They have to know like which planet are they going to colonize, and they take frozen embryos on the spaceship. Have like all these frozen embryos, and they're like, which planet do we pick? Because if we pick the wrong one, that's the end of civilization. So it always reminds me of that movie now that I just saw it recently, and I'm like, there's the whole population they put on the spaceship. You have to watch that movie just
yeah. And I tell patients always ask, how long can they be frozen? They can be frozen for decades. They're so happy. They're very happy frozen. We just had a baby born, I think not from us personally, but in the news, a baby that was frozen for 27 years. 27 years, that's crazy. And it worked. So anyway, frozen seems to be more successful if we can.
What should optimal thyroid levels be for fertility? Recent miscarriage at 10 weeks and thinking that's the issue. Ferd won't retest my thyroid level again yet.
Oh goodness. Yeah. Oof. So thyroid, normal thyroid levels for an adult are typically a TSH of 4. Okay, so we go by the thyroid stimulating hormone, or TSH. And for normal adults, it should be around 4. But for fertility and to reduce miscarriage risk, we prefer to see 2.5 or lower. Okay, and that's, in conjunction with the Fertility Association as well as the Thyroid Association, we find lower risk of miscarriage when the TSH is below 2.5. We also don't want it too low. Like if it's very, very low, that suggests an overactive thyroid, and that's not ideal either. I would say, depending on in early pregnancy, this is a very vulnerable time for thyroid changes, and thyroid should be checked. We always check a thyroid level during the beta trend to make sure everything's okay. If you are someone with a known thyroid disorder, I would make it a point to check very regularly in early pregnancy to adjust your medications if we need to. But if the miscarriage was very recent, it might make sense to wait until the hormone levels have gone to 0 to see where the true thyroid base is before making any adjustments. And that might be a reason why we're not checking it just yet. But yes, thyroid is very relevant to pregnancy, can be a cause of miscarriage, and definitely should be optimized before trying again and watched closely in your next pregnancy.
Some patients can really go up and down with the thyroid during pregnancy, but at that point you're like, okay, this is really bad.
Yeah. Okay, so if we're going into like an IVF cycle, I want to see the thyroid, I want to see it in normal range for an normal adult, below 4. Okay. But, and so if we're above 4, we need to absolutely treat that before starting our IVF, like making eggs and embryos. For transfer, I want it below 2.5 before we start our treatment, certainly before we go in for transfer. Now, quite commonly early in pregnancy, I see we're doing great, and then boom, we're pregnant, and now the thyroid goes up. We see it literally all the time. And I wouldn't, I personally don't panic. We just adjust your medications. And as long as we're on top of it, I make a med adjustment depending on how high it was, how much adjustment we're making. Maybe I'll check your thyroid again in a week. If it was very minor, maybe we check it again in 2 weeks. But as long as we're not looking at like levels above the 4 range,
well, we have
then I
another
wouldn't
miscarriage question
panic.
about do you see more miscarriages with chromosome normal embryos with fresh transfers versus frozen?
So when we're doing a frozen so if we know the genetics of the embryo, 100% this is a frozen transfer. Because in order to do the genetics, it requires freezing the embryo, waiting about 3 weeks for the results. So I don't think it's possible to do a fresh transfer with a normal embryo.
I guess maybe looking at the embryo report, but you wouldn't really know. I mean, you're just guessing. Yeah. Yeah.
We don't know the genetics. It could be a beautiful
embryo,
but doesn't
to retrieve from a
40
and a 6-month old patient. I guess 40 and a half is what.
Yeah. Oof. So, everybody asks me that, or, how many eggs when I'm meeting a couple for the first time, how many eggs do I have? And I have no idea until I do your ultrasound. Okay. I saw a 41-year-old today who has 40 eggs. And I was like, oh my gosh, she happens to have PCOS, which is maybe not great, but I was never expecting her at age 41 to have literally 40 eggs, but there she does. At 40, I would say having 10 eggs would be great. That'd be great. As we get older, we have lower numbers of eggs, but every woman is different. So you might even have a hormone level, an AMH test done. But your ultrasound to see how many eggs you have is very important as well. Sometimes the AMH and ultrasound do not exactly correlate, but the ultrasound is most important to see from an stimulation how many eggs would we be able to expect. So I don't know. How many would I expect from a 40-year-old?
The follow-up question was fresh transfer tested after miscarriage.
Fresh transfer. Oh, so it was a fresh transfer. You had a miscarriage. It was tested and found to be normal. So absolutely, I would recommend doing a frozen transfer next time because, again, after a fresh transfer, we have very high hormone levels. Sometimes that results in even just no pregnancy occurring. Maybe there were other metabolic factors at play. Once we have a miscarriage of a normal embryo, I automatically start thinking about other things. What are we missing? A blood clotting, an autoimmune factor, a hormone factor? Next time I would encourage frozen transfer to make sure that the elevated hormones from stimulation are not playing a role.
Do not give up because sometimes I think sometimes miscarriages they're horrible to go through, but they are a sign that your body's trying to do something, that it's really trying to do something it's supposed to do. So sometimes that is the stage before things actually start working,
Yeah.
Yes.
Implantation occurred, which is really good.
There's a question about to downregulate or not for adenomyosis. Do you do, I guess, things beforehand?
So I do like to before transfer, not before IVF, but before transfer, adenomyosis. So this involves endometriosis of the uterus. And I do like to downregulate with the Lupron. Okay. We have many ways to prepare the uterus for transfer. And the Lupron, it does involve downregulation, which can help to suppress the endometriosis, suppress adenomyosis. I do prefer that for transfer. Now, all of the data on transfer cycles, they've studied it. It's very difficult to study different transfer cycles because it's so different between institution, and it's just a difficult item or point to study. There's been found to be no superior stimulation method for transfer, but to me, it makes sense that if we use the Lupron to suppress the inflammation associated with adenomyosis and endometriosis,
sometimes for several months,
we should be hopefully
right?
more
I know
successful.
we have a few patients with that they're being suppressed for a couple months. So.
Yeah, yep. Depending on the extent of the adenomyosis or how our prior transfers have gone, I sometimes use just the 2-week suppression, or sometimes I have used
are there ways to improve AMH levels?
Standard.
We get that question definitely a lot. What is your take on it?
Yeah, so very good question. I would say what is in your power are things like making sure you are your healthiest self, not smoking, that can lower your AMH, making sure your diabetes is under control, or your high blood pressure is under control, or your cholesterol, or your weight. These are things that are in your control. If you have no medical conditions, if you're not smoking, you have a super healthy lifestyle, I don't necessarily, I don't know if there's anything proven that can improve our AMH levels. I always extremely recommend anyone with a low egg reserve consider acupuncture, because maybe the blood flow, increased blood flow to the ovaries, oxygen, nutrient supply, maybe that can help us. But nothing to my knowledge has
definitely,
been 100%
I read a while back that
foolproof
depends
to
also,
improve
like
AMH.
certain blood types have like a little bit lower AMH, regularly like O positive, which is interesting, So yeah, sometimes it can fluctuate a lot depending on the lab you go to as well, and then some people with very low AMH, they have good egg quality, so it's like,
Yeah, exactly. So there was a question towards the end, I think, about, would we be able to work with an AMH of 0.15? And the answer is absolutely. Okay. Age is really critical. So if you are young with an AMH of 0.15, that gives me a lot of hope. If we're beyond 40 with an AMH, that's it's going to be hard. Okay. But there are always options. And of course we would work with you to see what would fit, what would work best. And again, AMH is different from antral follicle count. And if on ultrasound we're reassured by number of eggs,
and there's some things about acupuncture
really
affecting
important.
the epigenetics of around the follicles and that sort of thing, which is pretty neat little rabbit hole to go down if you want if you like to read all of that. It's really cool. But there's things at play when you're doing certain treatments like that. And I think we don't understand everything that's happening in the body. As some people ask, like, how does it work really for egg quality, and how does it work for this? And they're finding out in China, doing these studies, that they're actually testing the environment that the little follicles are bathing in, and the ovaries, a little fluid inside that follicular fluid, that there's actually things happening where things are turning off that should be turning off, when we talk about inflammation and TN alpha and all these different things that could influence the quality, and then things are turning on that are beneficial. So it's pretty neat to look at it. Obviously, it's not happening overnight. A lot of these studies are 12 to 15 treatments. And someone asked how many treatments it's dose dependent. So if you are someone going into an IVF cycle with a low AMH, you want to give yourself some time. And that's with everything, nutrition, with, acupuncture, doing everything you can do to optimize, your supplement regimen, because you're going into it knowing that it's going to be a little harder for you, to perhaps stimulate or to that sort of thing. So, but that's definitely helpful. And then, getting that stress level down, I think it does impact. It has to impact it some way. Someone asked, like, does stress or anxiety impact FET? There are some doctors I know that will not do a transfer if someone's been fighting the morning of, like they're really worked up. They're like, you know what, this is not a good time. You know.
Wow. Yeah, no, that would be not ideal, not ideal. And actually, we're IVFMD is part of a study
Oh,
now that is
oh, cool. I didn't know
investigating
that. Very
whether
neat.
stress plays a role on IVF and transfer success. Um, through our parent company Inception, they partnered with, I guess there's a
Oh,
wearable device that's tracking probably heartbeat, maybe temperature, maybe other things, I'm not sure. But through this device, we'll hopefully monitor and assess level of stress and correlate that with
yeah.
IVF outcomes. So it's, stress is something difficult to study as well, hard to measure stress.
That's
So
super cool.
therefore
I think
challenging to
heart rate
study,
variability is one of the
but we're
measurements
going to
they
try.
could do, cortisol.
Yeah.
But heart rate variability you can definitely use through a wearable, or there's even certain beds now like Sleep Number, all those that measure that. You can do little experiments like, okay, I did
Oh,
acupuncture,
cool.
let's see if my heart rate variability was
Yeah.
better, or I took this or magnesium or those sort of things, or I did meditation,
Nice.
yoga. All those are important because I think they work on the brain, which the brain communicates with the ovaries. The ovaries
Yeah.
communicate back to the brain. It's a loop. So anything you can do, I think, to help that loop helps everything else work better.
Definitely.
And also, I always tell you, don't fixate on the number because you're more than that. You have so many more things than just the AMH. So just, I know that 0.25 will just burn into your brain, but it's stuff, I mean, or whatever it is, I think would you say 0.12 AMH? Yeah, I was looking at the TSH of 1.25, but all those numbers are just that. And we've seen
Yeah.
people even lower AMH get pregnant. So,
Yeah. I have a patient with a very low AMH, 0.15
yeah,
or
for
0.17,
sure.
and we've made embryos. So it's definitely possible. Absolutely. And Dr. Duro, so when patients are going through an IVF cycle, I always get this question, how often should I do acupuncture? What is your recommendation for patients when they're going through
Yeah.
IVF or FE
I
or
think
their
it depends
transfer?
obviously
How
on,
often should they
like
be getting
what they're
acupuncture
doing as far as
treatments?
their cycle. So we want to know like what's your treatment plan. If you're maybe going through like a frozen embryo transfer, usually we do twice a week during that month prior to. And then, with most patients, they have no issues with their lining. They're doing great. But there's some patients that struggle with that. So we might want to do like electroacupuncture, add additional treatments, a little bit of
Mm,
abdominal massage, those things to help encourage blood flow. There's some protocols that can help with that they've studied actually to show that the lining improves slightly, even 1 or 2 millimeters. That is good, for patients. So, but usually once you get your treatment plan, that's a
yeah,
good time to be like,
definitely.
okay, I think we need to ramp things up a little. But until then, usually once a week is totally fine. And if you're trying naturally or doing IUIs, or
Okay.
just trying naturally, we do once a week. And with IUIs, we might start to do twice a week as you get closer if you're taking Femara or Clomid or doing any injections. The same premise, just helping with, your body working better with the
Okay.
medications because your ovaries are working harder than they usually are. And also after the transfer, I think that's just
Right.
as important. I mean, most patients are feeling fine. They're worried that they're not feeling anything, and then they worry when they do feel things. So we kind of work on that anxiety part of that equation and try to work on, and blood flow still. And then we start doing our little anti-nausea points. Even before we see the pregnancy test, we're like, let's just start working on, just working on that so
Nice.
that if things start to creep up, it'll be a little better and it won't be full
Yeah.
blown, hopefully. So that's usually what we do. And then by like 10, 12 weeks, patients are
Nice.
feeling really well. And we just see them as needed. But yeah, I think pregnancy is important to still treat the patient and not just, drop off there. Yeah. Yeah.
Oh, you're done. Yeah. Great. Thank you. Are lymphatic massages okay to do through the IVF process? Um, so I would say the actual physical pressure of the massage, absolutely no problem. But Dr. Duro, as a result of lymphatic massage, do you think this releases toxins or inflammatory factors that have been, you know, they always encourage you to hydrate after, you know, a general massage because of all the factors that
the
might
purpose
be
of the
released.
lymphatic
Is that the
massage
same with the
is for
lymphatic massage, would
detoxification.
you
So I
say?
would want to do that prior to doing any transfer or IUI. You know, that's usually we're doing this post C-section, or we might do this for someone who's, you know, kind of going through a lot of, you know, colds and they're just sick. They have swollen lymph nodes and that sort of thing. But I don't, yeah, there probably is a reason why they want to do that. And I would look into what's that reason, try to do those way ahead of time. And then you can do Swedish, like super relaxing massage. Usually that's fine. I mean, we work with our prenatal, you know, once you're pregnant, but you don't want to do anything that's like going to put pressure on the ovaries or do any, you know, like too jarring or anything. So
Deep tissue. Yeah, agreed. Okay. Another question, which is a happy question. 12 days after
awesome.
ovulation with a beta
Congrats.
of
That's
83.
great.
I'd say that's amazing. Congratulations. It sounds like, you know, actually an early beta check after classic ovulation. Typically, we don't check the hormone level until 14 days or 2 weeks later. And I ideally want to see that level 50 to 100 or higher. So
cool.
83 with an early check. That's an amazing
Now I'm curious about
start.
that study too.
Congratulations.
Someone said, I saw that flare. I want to know the results of that study.
Oh, yeah. Okay, so, well, it's called the OTO study. And all of our IVFMD locations are participating. So it's really meant for couples who are going through their very first IVF cycle with an intention to transfer. And like not necessarily preserving for the future or doing egg freezing for the future. They're trying to get pregnant now. So if you're interested, you should simply, you know, speak to your doctor. They can get you in touch with the study coordinators to see if you're eligible to participate. Patients are paid to be part of the study, which is a nice little bonus. And you're wearing this wearable monitor, which looks like a, you know, Apple Watch or a bracelet. And I honestly don't know all of the details of the study, how long you have to wear the monitor, but
I wonder if they're excluding,
it seems to be pretty
they might be excluding
straightforward
acupuncture
and
from
easy.
that, probably.
Hopefully we have
I would think,
our,
like they
didn't, I mean, they didn't mention anything like that. I think they said heart conditions. Obviously, if you have a irregular heartbeat, if you undergo multiple cycles, obviously you're probably more stressed because this is tolling.
Cool.
But
okay,
yeah,
and then
curious to see the
Shirley's
results as
got
well.
a question. Well, does the body give any signs of period returning while breastfeeding?
Good question. I would say, at least from a personal perspective, I was always just surprised whenever the period came. So I've had 3 pregnancies, and I breastfed all 3 pregnancies. In my first pregnancy, my period did not come until I stopped breastfeeding completely, and it pretty much came like very next week. It's like, oh, all right, you're done. Here I come. In my second and third pregnancies, it came early on while I was like after 3 months. And did I have any warnings? No. Maybe some cramping, but I would say, you know, physiologically, while breastfeeding does often suppress ovulation because your body, you know, is focused on supplying the new baby, and energy is focused on feeding the new baby. At some point, if the amount of food that the baby's intaking is reducing and maybe it's having more solid food, or as the frequency of breastfeeding decreases, then the body is extremely smart. It starts to siphon off energy from breast milk production and refocus on, okay, let's bring on next baby. So it's difficult to predict when the period will come. It could be while breastfeeding. It could be not until you've stopped. In general, it's not a good way to view, use breastfeeding as your only birth control if you're not planning a new pregnancy, because the period could come back at any point, and the period is actually the end result of ovulation. So if you're very sensitive, maybe you will notice that you're starting to ovulate at some point. But at least from my personal experience and other patients, it's kind of had no warning when the period comes back.
Tried to get pregnant for 5 years, and she ended up getting pregnant, and then getting pregnant again when she was breastfeeding 3 months after she delivered. And it was like, I didn't use birth control. I thought, there's no way I could get pregnant. There's no way. So they almost were born in the same year. I guess it's called Irish twins or something when they're almost the same. Yeah. So that definitely, it's really kind of surprising. Sometimes things get revved up a little bit when you're after you deliver.
Yeah, your body just wakes up. I have, oh my goodness, I think I have 2 patients right now that were, at least 2, maybe 3, that have had IVF pregnancies for their first baby, and then boop, suddenly pregnant, which I love. I think is the absolute best. The body, something changes after a pregnancy, and it's not uncommon. It's not something that we can guarantee is going to happen, but it's certainly not uncommon to have natural pregnancy after IVF, which I think is just wonderful. Yeah. So then other questions. I had a baby delivered in October. This was an IUI baby. How long do I need to wait before starting to try again? So according to the American College of OBGYN, it's best for your body to wait at least a year. Okay, whether that's vaginal delivery or C-section, your body goes through quite a toll through pregnancy and then delivery, postpartum, and to really have the best nutrients restored, ACOG advises waiting this entire year. Now, for couples who have faced infertility in the past, that's just unacceptable, and the year seems like an intolerable wait. And it doesn't necessarily mean exactly at that year mark that you're going to get pregnant. So for my patients, if it's a C-section, I say yes, we absolutely need to wait the year because the uterus needs to heal. We don't want to create a dangerous pregnancy if we get pregnant too soon and start expanding the uterus in that vulnerable area. So for my patients with a C-section, I say, yes, we need to wait a year, but we can start our test. We can regroup. We can look at our testing. We can look at the uterus. We can get everything all set up. And then immediately at that year mark, we start trying again. For vaginal delivery, I'll give them 6 months. I would say, let's give your body at least 6 months, and then we can start trying again. But the gold standard ACOG board examiner.
I know it's tempting with the embryos there, sitting there frozen, like, okay, let's go. There's a PGT question here. PGT is going to tell if the embryo is male or female.
It will. And is that my patient, Yanina? Hi, Yanina. I have to call you. I have your results. They just came in. I have to call you, Yanina, but it's great news. So exciting. So yes, the PGT tests do tell us that if it's a boy or a girl, the PGT stands for pre-implantation genetic testing, which is the test of the embryo. It's typically primarily being done to see if the embryo is normal or not normal. And it also tells us, but it tells us if it's normal or not normal by looking at the chromosomes. But then it also tells us, as a result of looking at chromosomes, is it a boy or is it a girl?
Like, so yes, we do know. Show me, but it's hard.
I will call you tomorrow.
Hey, Rebecca.
I know.
Yay.
I know.
Congrats.
And my patient. Hi, Becky. Yes. So excited. Can't wait for ultrasound. Very good to see you, Rebecca. I think there were a few other questions that came in ahead of time. How do I know if I'm a good or bad candidate for IVF? So that's a very good question. In general, IVF is most successful when we have a good number of starting eggs. And ideally young age. So, you know, the people who most need IVF is typically as we get older, it becomes more difficult to get pregnant because of egg quality and egg number. So the people who most need IVF, unfortunately, are typically older. And sometimes, no, they are not the best candidate because of our egg numbers or ovary hormone levels. So it's a balance. And, you know, yes, a 25-year-old with tons of eggs and high hormone, you know, that's ideal. They're going to do fantastic with IVF, but do they need IVF? Probably not. A 40-year-old who has a low number of eggs, they need IVF because of the quality that occurs with as time changes. But are we going to be a slam dunk? No, it might be more challenging. So it's really difficult. And where we draw the line is really patient doctor specific. At least at our center, we do have certain protocols. We have a cutoff for IVF. I don't know if that's well known, but we have certain ages where we say, no, you should not egg freeze because of the quality of eggs. We cannot guarantee that these are going to be successful in the future. We do have a cutoff for IVF, couples trying to make embryos, because we feel like it's very important to be mindful, ethically mindful of this. You know, this treatment is a big treatment. It's not without risk. It's very expensive. So our treatment comes with significant risk. We want to make sure that we're putting patients who are good candidates through. So we do have cutoffs. There's exceptions, and we always have exceptions to the cutoff. But it's something that it's a fine line between patient and their doctor, whether you are someone who would qualify or not. But ideally, great number of eggs, younger patients.
There was a question about
but they're not necessarily the people who need IVF.
Answer that? I'm not sure. A patient having a transfer in May. Any recommendations for people with antiphospholipid?
So if you were my patient, I probably would have you on a baby aspirin and Lovenox. Yeah, I would probably start you Lovenox with your transfer. Definitely. Sometimes, depending on your history, patients are started on it, you know, with your medication start. Sometimes we start it with embryo transfer, but my classic treatment of antiphospholipid would be Lovenox and a baby aspirin. Depending on your history, sometimes there's a role for a very extreme treatment, IVIG, but I would reserve that for a very select population.
Throughout
mostly it's Lovenox and a baby aspirin.
First trimester, right? Usually like till week 10 or so.
Yeah, I would stop typically around week 12, unless there's other reasons in the history that we should continue it for the whole pregnancy.
I think that was, okay, there's a question. Does bloating significantly increase during retrieval or just during the stimulation?
I would say both. So side effects of the IVF are that instead of one egg growing, we're growing a ton. So you're going to start feeling maybe just a little bit bloated because ovaries are getting a little bit bigger. But then towards the end of the stimulation, we suddenly have hopefully lots of eggs growing. So your ovaries are double, sometimes triple in size. So you typically feel your peak bloat the day of trigger, the day of egg retrieval, the day after. Now, unfortunately, at egg retrieval, even though we're going in to collect all of the eggs, we drain all of the fluid, the ovaries don't immediately collapse to their normal size. In fact, where those eggs were growing, they now fill back up with blood. So the ovaries are still as big as they were right before we retrieved them, and now they're heavy because the blood is heavier than the follicular fluid. And so you still feel quite bloated. In women with very, very high egg counts, we see a risk of overstimulation or ovarian hyperstimulation syndrome. And sometimes the bloating is actually worse the week after egg retrieval. So that's, if I have a high suspicion of that, I'd like to check in with my patients a few days after egg retrieval, make sure they're feeling okay, see how their bloat is doing. We can try to be proactive and use certain medications to prevent that bloating. If we're not worried about overstimulation, then I would say, within 2 to 3 days, we should feel significantly better. Okay.
Yes.
By a week to 2 weeks, you feel almost normal.
Some people keep mentioning the French fry
majority.
thing. Like, should I eat McDonald's French fries? I don't know if that means after the retrieval, during transfer. Like,
no. So the basis for that, I think, comes from the fact with overstimulation, we encourage salty foods, electrolyte foods. We used to be doing fresh transfers back in the day. And so you'd have your egg retrieval, you go have your French fries, and you're having your egg retrieval a week later. And we're trying to avoid overstimulation symptoms because we have our fresh transfer the very next day. And we can try to minimize overstimulation with electrolytes, salty foods, high protein. So I think that's where this.
They had a lot of soybean oil or something. I guess like the intralipids.
But
so that's what
let's be honest.
I'm not sure exactly.
Oh. Okay.
No.
I would say McDonald's French fries are not the healthiest, and we have many other electrolyte Mediterranean diet safe options.
But everybody wants
for
those French
your
fries.
post-retrieval
treatment. They keep asking.
Yeah. But you also get you just had a procedure. You
not kill you.
They won't kill you. To have some French fries that day if you do. So just crave them. Yeah. Other questions that have come in. Let's see. There was a question about subchorionic hematomas. Our subchorionic hematomas are common. How long do they take to heal? And I would say these are extremely common. I see them almost in every OB, pregnancy ultrasound that I do. And if I don't see that, I'm like suspicious and I keep looking. Like it's gonna be there. It must be there somewhere. So that's all to say. I almost always see little hematomas. And they occur in natural pregnancies. They occur in IVF pregnancies. What they are just a little bleed between the pregnancy and the side of the uterus. And why they occur, we don't know. We often don't know. But I would say they are very, very common. I typically, recommend activity restrictions to prevent bleeding. When we see them, sometimes they can cause spotting or bleeding, which is scary. No one wants to see that when they're pregnant. So I tend to be very conservative and recommend, no exercise, no lifting, no sex to try to avoid bleeding from these little hematomas. But they're often no concern at all. They typically do go away. Maybe the next week you have an ultrasound, it's no longer there. Maybe you go off to the OB/GYN, they no longer see it. It's something we typically most commonly see before the placenta is forming. And that starts to happen between week 9, week 10. So once we are at that point,
they are very common, right?
No worries. Our placenta's in place.
It is not pleasant to have that. Yes, those little spotting and everything is not,
like literally
not
almost
pleasant,
every
but it is normal a lot of times. So, how soon after a failed transfer do you wait before trying again, assuming the woman is healthy?
Yeah. Oh, I'm sorry if you've experienced a failed transfer. That's always really devastating. For my patients, if we've had a failed transfer, I'd like to regroup immediately, that week if we can, and see, are there any clues to what happened? Why might this have happened? Was this a normal tested embryo? Was this not tested? Is there additional testing that we would want to do? Would we want to change the protocol? Are we down to very few embryos? Should we make new embryos? But physiologically, your body's ready to try immediately. Okay. But sometimes with your doctor, there might be some further investigation you want to do before trying again.
About back-to-back transfers, or is that more like IUIs that are?
I would say no, other
Yeah.
than like waiting too long is tolling mentally for the patients, and being lost to follow up that, you know, does never result, almost never results in good outcomes. So there is something to say about just
So
keeping
sorry to
going,
hear that you're
and
hanging in
we
there, and
will be successful.
it's going to it's going to take some time. Sometimes, you know, it takes a little while to kind of get ready to go, like psychologically, back into a transfer. But um,
Exactly. Exactly. Um, Good. I don't have any other questions that I
I
saw
think
that
we
were
got to
being sent
everybody.
in
So
early.
that's that.
Um, and it's also pretty much 7 o'clock, so another
Thank
solid
you.
session with
Thank you
Dr. Duro.
for
Thank you so
answering all
much
these
for
questions, and
joining
thank
us
you guys
tonight.
for asking these amazing questions, because I always learn something new every time as well, even though, you know, we're here for you. And if you guys ever want
Yeah,
to message us, you can, you know, message us through Instagram or give us a call. We're at FL Complete Wellness. If you want to follow us, that's great too. And I know that you guys offer virtual visits as well, even if, you know, you're not in South Florida. Then where there's a will, there's a way. So here to help.
be anywhere in the world. Wonderful. And if you join late, you know, we're going to upload this recording to the IVFMD website, so you can, or to the IVFMD Instagram
Yes.
account, you can
Thank you, Dr. Palmerola. Thank you, guys.
rewatch the
Have a good
entire
night.
session at your leisure.
Bye, everyone.
Yeah. Well, have a great night.